Now imagine this. The Cuban doctors pack their bags. The scholarships slow down. The Jamaica-Cuba medical program is cut back or cut off. What does that look like on the ground? Who pays the price? And does Jamaica finally fix its own system or just fall deeper into crisis? The effects are felt almost immediately. Clinics and hospitals that depended on Cuban staff suddenly face staffing holes they cannot fill. Rural health centers that ran on 1 or 2 Cuban doctors now operate fewer days a week or stop operating altogether. Waiting times balloon. Services that were already stretched begin to snap. The Jamaican staff who remain become more overworked. Burnout rises. Attrition accelerates. Removing a support pillar doesn't just reveal the cracks, it widens them. Patients don't experience policy change. They experience longer lines, cancelled appointments, and more trips to private doctors they can't afford. Politically, the fallout is swift and multi-directional. Communities that lost services demand answers. Unions that wanted more local hiring ask why the government never built the pipeline. Opposition parties smell blood, and the government is caught between constituencies that wanted the program gone and constituencies that needed it to survive. Budget pressure intensifies. Jamaica must now choose between increasing pay and incentives to retain its own doctors or allowing quality to quietly erode. New deals may be struck with other countries, private hospital chains, or international agencies. But cutting the program without a serious replacement plan is like firing half your staff and then announcing a strategic vision. The press conference looks good, the emergency room does not. And yet, there is another way to read this moment. Dismantling the program could be a chance to reset. Expand local medical school enrollment, offer better retention packages, reform the management and infrastructure that drove Jamaican doctors abroad in the first place. But these changes don't happen automatically just because the program ends. They require political will, money, and time. Without that, the vacuum left by Cuban doctors becomes just that, a vacuum. So who really pays? Rural communities with few private options are hit hardest. Poor households lose access first. Those with money pivot to private care and carry on. The gap between those who can afford to be sick and those who cannot grows wider by the month. In the abstract, dismantling the program can be sold as reclaiming sovereignty, ending dependency, or pivoting away from socialist allies. But in the waiting room, sovereignty looks like a mother with a child on her shoulder, waiting 6 hours to see the one doctor left. The Jamaica-Cuba medical program was never perfect. It masked deep structural issues and made it easier for leaders to delay hard reforms. But it also kept real human beings alive and treated in places that would otherwise have been abandoned by the system. Dismantling it without a serious, well-funded plan to replace that capacity isn't just a policy choice. It's a decision about whose lives are easiest to sacrifice. And that is a question no government should be comfortable leaving unanswered. So here's what I want to ask you. Do you think Jamaica should aim for full medical self-sufficiency, even if it means years of pain in the transition? Or is there a smarter way to mix foreign support, like Cuban doctors, with a real investment in local professionals, so that partnership doesn't become dependency? Drop your answer in the comments. If you want more deep dives into how small countries navigate health, power, and geopolitics, hit subscribe, turn on notifications, and share this with someone who still thinks these programs are just about ideology, not about who gets treated and who stays sick.